Thanks very much. Jack, first of all, thank you for inviting me to speak today, and thank you also for all your advice up to date in trying to navigate what is unknown territory. Ebola has really gripped all of us, and it's really great to see so many people here and all of us trying to navigate this territory together. But certainly when you read articles like this, I came home from the States today and found this on my desk, and when you read the predictions of what can happen if this is not contained, then it really is very serious indeed, and should give us great concern. I was interested to note, however, in the US they were being relatively calm about things, and the recent outbreak in New York had prompted a big reassurance about the standard of healthcare in the US and their ability to contain outbreaks. I would argue there is no room for complacency, and I think we have to be careful. There's very little information about pregnancy and early neonatal life, just because the data is coming from areas that are not so developed where there's unrandomized data, and we really are just getting case reports and reports from the ground. We don't have information on what outcomes would be in the developed world where good care is available, or some care is available, and it's important to remember that for many of those communities affected, there really is scanty, if any, care available. The case fatality rate seems to be much higher in pregnancy than outside, and actually we see this in a number of infectious and viral illnesses. Case fatality rate in West Africa in general has been reported to be anywhere between 55 and 75%. I'm sure other presenters have given all this data. But what's really important is that in the fetal and neonatal cases, the mortality currently is understood to be approaching close to 100%. And that's really important because that's going to inform, I think, the level of intervention that you're going to sensibly undertake, knowing that the outcome is so dismal. I suppose the primary objective of all of this is to prepare us to contain a case should it happen, so that we protect our community from an outbreak of Ebola in Ireland. But I think it's also very important. I have 800 staff working in the National Maternity Hospital, and I think it's really important for them to know that the priority is also to train and educate our staff so they also are protected and can provide supportive therapy within reasonable limits. So in the most part, it's going to be about identifying high-risk cases. So most of the effort for all of our staff is going to be devoted towards being able to pick these cases up and identify and knowing what to do then. Every single member of staff does not know how to deliver a baby in the context of Ebola, and I think that's very important. So it's going to be the screening and the picking up that's going to be universal, and then we have a team appointed already in our hospital, the high-risk team composing senior midwifery staff, senior anaesthetists, senior obstetricians, and we are lucky enough to have Susan Knowles, our consultant microbiologist, who's our Ebola virus contact, if you like. And then we also have the support of the NIU. So, the phone will probably be one of the most important tools in preventing outbreak of Ebola. For us, we're obstetricians, so we're keeping it simple. Identify, isolate, and then inform. So the first key is to identify. The next will be to isolate the patient, and then you have a little time to work out exactly what happens next. But obviously, exposure will be less prevalent than symptoms. What I mean by that, people will present with high temperatures, with fevers, with all kinds of symptoms that could be in keeping with any viral illness, including Ebola virus. And we must begin empirical treatment depending on what the clinical differential is and what our suspicion is. Because, as is pointed out by Karina, we do not want to miss obvious diseases and delay treatment in patients who are very likely not to have Ebola and require routine antimicrobiological treatment for other diseases. So it's very important that, as well as testing for Ebola, we're testing for the other diseases as well, and that's been well covered today. So the three screening questions really are, we're trying to assess how likely are you to have been in contact with Ebola. So have you travelled to West Africa, Liberia, Sierra Leone, Guinea in the last 21 days? And have you had any contact with an individual with Ebola virus infection? And what kind of exposure have you had? So I think it's very important to work out just those key principles. Have you been to that area? Have you had exposure to any body fluids? Have you had contact with someone who's had exposure to an Ebola case? And how likely is the case? So this is the American College of Obstetricians. So they're defining a person under investigation as somebody who has both consistent symptoms of a viral illness and risk factors. So we've gone through all the symptoms, fever, headache, weakness, etc., but also the epidemiological risk factors. And they're not going to be that common in this part of the world. We do have, now that Nigeria is off the list, we are not going to have so many patients travelling here from West Africa. It can still happen, but I think while Nigeria was still on the list, then these cases were really likely to be reasonably large in number. So that's our risk factors, and then a confirmed case is obviously somebody who actually has it. The American College point out that if you are testing pregnant women, and I'll take advice on this, but they do say you must have been symptomatic for at least 4 days before a negative test can be confirmed as a true negative. So just they caution, be careful if it's the first day and you've no thing, but I take advice on that. The next thing is isolate. So the first thing is, one of the likely scenarios is a pregnant woman who's recently returned from an area with Ebola, but they haven't had direct contact to the best of their knowledge, but they have been in a region where Ebola might be. So if they happen to ring you up, I suppose you don't need to invite them into the hospital if they're well and there's no obvious obstetric problem. It is very reasonable to wait some time before they access their routine antenatal care. Obviously, you can take a history over the phone, and if there are emergent obstetric complications, that's a different matter. But if all is well, then it might be reasonable that somebody would remain as an outpatient. Also, if somebody rings, I think it's reasonable that they may remain at home, and you can then contact your Ebola virus person in the hospital, take some advice on the history that's been presented to you, so you can work out how best you should go forward. If someone happens to present to National Maternity Hospital and they are pregnant and they have a significant history and we are worried, then the first thing is to isolate them. And that is when then the Ebola virus person is contacted, and that's when the trained team will then take over the further management in conjunction with the NIU. And obviously staff should be instructed to avoid touching the patient. So again, as Karina was saying, it's distance away and minimise the patient's exposure to others. And obviously in a case where there is a significant concern, so someone's got the epidemiological risk and they've got symptoms, then those evaluating the patient should be trained and use PPE, and only those who are carefully trained in PPE should be with this patient. So I would advocate in each hospital that there is a senior team. And for example, we've asked the anaesthetic team to take all the bloods because they're less likely to have a needle stick injury, rather than sending in junior staff who will be more at risk. So what happens if somebody needs emergency obstetric care? So they're having a baby, there is a hemorrhage, there is a miscarriage, and these are all topics that have concerned us and have led to great discussions. Well, this is a little bit different. So this patient would not be on your routine labour ward accessing the usual sort of obstetric care. So the American College are not recommending interventions such as fetal monitoring, because you're really not going to act on this. And it sounds very harsh, but if you have an abnormal CTG and a mortality rate that's estimated to be about 100% anyway, then you have to ask yourself, why would you do an emergency cesarean section if you're not going to alter the fetal outcome, but you would put the mother at risk if she's already compromised from sepsis, and you would also put your staff at risk without really any guarantee that you're going to improve the outcome. So by and large, wherever possible, cesarean delivery should be avoided. Obviously, in cases where maybe a need arises before you have confirmed the case of Ebola, or where always people fall off algorithms, then again it should be a multidisciplinary team that has a little discussion about the patient and decides what would be the best thing to do. Induction should be out of the question. There should be no reason to induce someone or artificially start off a labour, and people generally recommend that no episiotomies are performed, and that in the event of laceration, which is quite common after delivery, that these would not be repaired as a primary procedure. And again, all planning, because none of us will have dealt with a woman having a baby with Ebola, so all the planning, all the discussion should be a multidisciplinary exercise. So in general, we would anticipate a spontaneous vaginal delivery where somebody presents either in labour or late in pregnancy. During labour, vaginal examination should be minimal. I think it goes without saying that we would not use fetal scalp electrode, we would not use fetal blood sampling, and by and large, you can avoid vaginal examination, and certainly it is not recommended that you would artificially rupture membranes. So it's very much a hands-off approach as a practical matter, and I know this sounds funny, but anyone who's been at a delivery, there is a lot of liquor, there can be a lot of blood, there can be a lot of splashing, so you've got to be very careful how you position yourself, and you certainly need your PPE gear well on. As we've said, no episiotomy, no suturing, and of course there needs to be very careful handling of blood, of waste products, and I think we've all been trained, and we'll be training staff in the appropriate disposal of this, but I would be hoping that by the time a patient is delivering a baby, they will be in the NIU. We would be advocating where possible early transfer out of the hospitals where is possible. The big risk or the big worry we have, particularly in the context of sepsis in pregnancy, is hemorrhage. So 10 to 20% of your cardiac output is going through your uterus any minute. So uterine atony is a big problem, retained products a big problem, and obviously hemorrhage is a potentially devastating consequence of delivery. So again, people are advocating, we normally put up oxytocin infusions, and people are advocating that we would rely on drugs like misoprostol, which can be given orally as first line treatments, and then maybe a second line consideration given to IV and IM drugs, assuming that the lines are there and that people are comfortable and happy and the appropriate precautions have been taken that they can give these drugs. Intrauterine procedure should be avoided. So, for example, with an incomplete miscarriage, you're likely to try and manage this using misoprostol or medically than you are to do a surgical evacuation. But there will be difficult scenarios in that you have an obstructed labour or you have a woman who's hemorrhaging, and it's how much care you can offer. Spontaneous miscarriage is common in women infected with Ebola virus, as it is with any condition that leads to sepsis or any infection. So extra caution should be taken in the assessment of women who present with bleeding in pregnancy and those who have an Ebola contact history. And it's very sad, this slide, because it's very unlikely that a baby will be a live-born baby. In the majority of cases, babies will likely, where there is infection, there's a very high risk of intrauterine death. And woman will still need to deliver her baby, but we would usually opt for expectant management in that case. But with the information that we have at the moment, the outcome for a fetus whose mum contracts Ebola is very poor indeed, and there's a high likelihood of intrauterine death. But in the unlikely event of a live birth, the baby must be assumed to be Ebola positive and handled in accordance with all of the things that we have been discussing today, and full PPE. Obviously, if EVD is suspected, sometimes you can't imagine someone comes in, the labour is cracking on, you don't have time to confirm your diagnosis of Ebola, but where you are highly suspicious, obviously she is treated as Ebola positive until you can prove otherwise. And you may also be instituting other treatments for your differential list, particularly malaria and sepsis with broad spectrum antibiotics. So regardless of decisions regarding the limits on resuscitation, obviously care directed and comfort should be provided to infants who are live born from mothers with EVD. So again, really you're looking at supportive therapy for both of these, and again we'll need expert neonatal input as to what care is reasonable to offer these babies, and that will depend on their clinical condition at birth and what is reasonable. So again, emphasising the need for multidisciplinary input and the need to discuss with all of the experts what might be the best thing, because there's unlikely to be a perfect algorithm for all of the potential scenarios that are going to develop. So the principles are the same: identify, isolate, inform, but we've got to be ready to have a variety of discussions. Breastfeeding is not recommended. Breast milk carries the Ebola virus, and this continues for an unknown length of time in the convalescent and surviving patients. It would be preferable to bottle feed babies, and that's really all. I'm happy to take any questions later.